Welcome to the April 2024 LACNETS educational event. I'm Kavya Velagapudi, Executive Director of LACNETS.
I'm Lisa Yen, Director of Programs and Outreach for LACNETS.
And I'm Heather Davis, Associate Director of Advocacy and Outreach at LACNETS.
Today's presentation is on 2024 updates on clinical trials in neuroendocrine tumors. A special thank you to our supporters, Ipsen, ITM, Crinetics, and Tercera. LACNETS stands for Learn, Advocate, Connect Neuroendocrine Tumor Society. Our name also states the mission of our patient advocacy organization. The LACNETS staff includes Lisa Yen and Heather Davis. The board includes Donna Gavin, who is the sister of LACNETS founder Giovanna Joyce Mbesi and NET patient Mary Dunleavy, who has been living and thriving with NET for 19 years. We're excited to share that LACNETS is partnering with the Carcinoid Cancer Foundation, or CCF, to provide support line assistance and other programs. For more information, visit lacnets.org/supportline. Now I'm going to hand it over to Heather.
Thank you, Kavya. This webinar is being recorded and can be viewed on the LACNETS YouTube channel shortly after this broadcast. Our YouTube channel features over 300 videos and podcasts. Use our playlist to find webinars on PRRT, liver-directed therapy, clinical trials, imaging, nutrition, Theopera, our annual conferences, and patient stories. You can also find videos by topic in our new video library found on the homepage as well as our Learn tab. Follow LACNETS on social media. We are on Facebook, X, and Instagram with the handle @LACNETS. And please be sure to add us to your Safe Sender email list. I'd like to remind our audience that LACNETS webinars are created for educational purposes and do not substitute for medical advice. The views shared in this webinar are the experts' personal opinions. Please contact your medical team with questions or concerns about your individual care or treatment. And now I'll hand it back over to Lisa.
Thank you, Heather. One of the challenges we often hear from patients and caregivers is finding information about specific clinical trials, and in particular, information that is easy to understand. As a wife and caregiver of someone living with metastatic NETs for over 9 years, I can relate to this. We want to stay informed and engaged with clinical trials as we explore possible current or future treatment options. This is why LACNETS created a clinical trials guide, an easy-to-use educational resource that features several key clinical trials for neuroendocrine cancers. There's also a clinical trials finder on the website. You can browse the site by type of neuroendocrine cancers. You can also browse by some of the types of treatments, and you can find brief, patient-friendly videos and information about each trial. We hope our clinical trials guide can help you better understand clinical trials for neuroendocrine cancer. I'm pleased to introduce today's speaker, Dr. Heloisa Soares, a medical oncologist and neuroendocrine cancer expert from Huntsman Cancer Institute, University of Utah. Dr. Soares received her medical degree in Brazil, where she was born. She completed her residency training at Mount Sinai Medical Center of Florida and her hematology oncology fellowship training and PhD in molecular biology at UCLA. Dr. Soares serves as the medical director for the clinical trials office at Huntsman. And nationally, she serves as a vice chair for the National Cancer Institute, or NCI, NET Task Force. She also recently served as a member of the board of directors for the North American Neuroendocrine Tumors Society, or NANETS, and she is the chair of the NANETS inaugural NET Patient Action Team, or the NETPAC Committee. Dr. Soares is clearly a patient advocate that is passionate about what she does, and she is deeply committed to finding new treatments, breaking down barriers, and bridging gaps in care. This is personal to Dr. Soares because she supports her brother, who is also diagnosed with NET and thankfully is doing well after surgery. Dr. Soares truly understands the value of community and how it takes all of us to move the field forward. Almost exactly 1 year ago, Dr. Soares gave a fantastic presentation on the latest in NET clinical trials, and we asked her to return again today to share updates on NET trials. Today's presentation will focus on well-differentiated NET trials, and next month, Dr. Aman Chauhan will join us to discuss neuroendocrine carcinomas, or NEC, and small cell lung cancer. Welcome, Dr. Soares. We're glad to have you.
Hello, everyone. My name is Heloisa Soares, and I'm a medical oncologist at the Huntsman Cancer Institute at the University of Utah. And I am neuroendocrine tumors or neuroendocrine cancer as my specialty, and I lead the destination care program for NETS here at the university. Thank you so much, LACNETS, for having me. I'm very happy to come back in this year to give you a little bit of updates in terms of clinical trials that are related to well-differentiated neuroendocrine tumors. And this is an update from my conversation with you from March and April of last year. So super exciting to show some of the progress that we have. Without any further ado, let's dive in. So as I mentioned before in my other lectures, there is what's called disclosure for conflict of interest, meaning if I ever give any advice to a pharmaceutical company, I should make sure that everyone is aware of that. And I had given advice or consulting in the form of advisory boards for Ipsen, AstraZeneca, Exelixis, and Novartis in this last year. My other conflict of interest is that I am a medical oncologist and I focus on clinical trials. I'm the medical director for the clinical trials office at Huntsman Cancer Institute, and therefore I'm a really strong believer in doing research and discussing clinical trials with patients, and to be honest, with my family as well. So I showed this a year ago when we chatted, but I just want to include this again because maybe there are folks here that didn't watch our initial discussion last year. So what is a clinical trial, right? Clinical trials are studies that are designed to find new ways to prevent, detect, control, and treat a disease, such as cancer. The goal is to find if a new treatment is, number one, safe, and number two, has efficacy to treat or prevent a particular disease. And when we do clinical trials, it's really important to include all type of people, from the age that they have, the race, ethnicity, gender, and even geographic location, because all these aspects can influence the response of the treatment at a particular person. So it's important to have diversity in our clinical trial population as well. What are the phases of a clinical trial? When you go and discuss the opportunity of a clinical trial with your doctors, they might say, oh, this is a phase 1 trial, this is a phase 2 trial, or a phase 3. What does that mean? So a phase 1 trial is a study that the goal of the study is really to look at human safety. And that can be human safety of the drug itself that has been used for the very first time in humans, or it can be a combination. So for instance, we already know that everolimus is a safe drug. But what if you combine everolimus with drug X? Is the combination also safe? So before we do large studies on that, we typically start with a phase 1. Also phase 1, as I mentioned before, is if we're testing a drug for the very first time on a patient, that's called phase 1, first in human, because really we're just learning about the toxicity. And the way that we do that, we go into steps. We start a very low dose of the drug as we see that the drug is safe after treating few patients and waiting for a determined period of time. And if there is no signs of severe toxicity, then we then move to the second stronger dose of the drug. And then we keep doing that until we reach what we think is the maximal dose tolerated or expected. And then once we figure out what's the maximal dose that is safe, then we move to phase 2s and phase 3s if it gets promising. Phase 2s are studies that are larger than phase 1, and they tend to look at extended safety and also some efficacy. And then on the phase 3 is when their studies are comparing a given drug or treatment strategy, normally against what is already standard of care for a particular situation, or with placebo or no treatments, depending on a given situation. And as we talk about some of the trials that we are going to be discussing today, you will see examples of these phases. Also, I think it's important to mention that trials that we're focusing here are focused on systemic treatments. So these are clinical studies that are looking into drugs that are going to be used for patients and then have a systemic effect. We're not talking about liver embolizations. We're not talking about trials that look into surgical strategies, right? These are typically pills or IV medications that we give to patients. And normally we think about the treatment of neuroendocrine tumors, especially in the treatments that are approved, in 4 different categories. The somatostatin analogs, and then the hormone shots. When baby, who knows, maybe it might be a pill in the future, and we'll talk about it. The TKIs, which are everolimus, sunitinib, and cabozantinib, and we'll talk a little bit more about cabozantinib. Chemotherapy, which can be in an IV form or can be a pill form. Capecitabine plus temozolomide is a form of a combination of chemotherapy that is given by a pill form, for example, and PRRT, which is radiation and radioisotopes that are actually given to the patients through an IV line. So these are the systemic therapies that we have that are options for neuroendocrine tumors right now. So in terms of somatostatin analog shots, again, this typically tends to be the first line treatment in patients that have disease that is required to need either control of the disease grow or symptoms. And I'm going to share with you results of a recent study. So last year, I mentioned that Dr. Hamon Shalman with some colleagues were investigating the use of an oral somatostatin analog in here for the treatment of carcinoid syndrome. And when we think about carcinoid syndrome, the 2 things that come into mind as the classic symptoms are flushing, that your face turns red, and diarrhea. And then this study is looking to this pill for the treatment of carcinoid syndrome. And this was a study that looked into the safety of the disease as the primary endpoint. It was an 8-week study that patients were randomized, meaning there was a choosing by a system or a computer, which is completely random, whether the patients will receive a higher dose of the drug, which is called paltusotine, versus 40 milligrams of the drug. And then these patients were monitored. There were 36 patients that were enrolled in this trial, and 30 completed the study. And what are the results of this study in terms of efficacy results? They saw rapid and sustained reduction in patient symptoms. There was a 63% reduction in the flushing in patients that had flushing for more than 1 a day. The severity of the flushing was although decreased. There was a 60% reduction in the frequency of bowel movements in patients that had more than 3 bowel movements a day. There was also a reduction in the urgency to go to the bathroom in terms of bowel movements in 64% of the cases. In terms of safety, the drug was very well tolerated with no treatment-related serious side effects. The list that you see here is about the side effects that were mentioning more than 10% of the time. And they were diarrhea, abdominal pain, nausea, headaches, flushing, and fatigue. The flushing is hard to differentiate it, but whether it's the flushing from the carcinoid syndrome versus from the drug, or even the abdominal pain. But these in general are the side effects that are seen more than 10% of the time. And they're very similar to the side effects that we see with the somatostatin analogs done as the short version in the butt. And also there is no new side effects that were of concern at this point. Based on these very exciting results from this study, which granted was a small study that didn't compare with a different strategy, but this is so promising that the study now is going to be moving to phase 3 study where the drug's going to be compared with the standard of care. And the study has not been activated. I think it is still being designed. And I believe that this is going to be focusing in carcinoid syndrome again. So the focus will be for symptom control, not necessarily for disease control. But this is, I think, is an evolving discussion, and we'll see when the study opens what is the final design and criteria to participate on the study. So what are the ongoing studies that we have with somatostatin analogs? So Dr. Singh is the leading global PI for this study that is looking into a different version of octreotide subcutaneous depot, or CAM 2029, versus either octreotide LAR or lanreotide subcutaneous in patients with well-differentiated neuroendocrine tumors. Patients have to be fairly new diagnosed or been diagnosed in the last 6 months to be part of this study. They have to have positivity of the tumors in a dotatate PET CT scan, and they have to have a good performance status, meaning have enough energy. And this is a global study. The good news is that we can no longer include patients on this study because they complete accrual. So all the patients that needed to be entering the study have been, and now the ones that are doing well are continuing the study, and we're waiting for the results to mature, and hopefully we will have results in the next few years. Perhaps by 2026, we might know if this octreotide subcutaneous depot, the CAM 2021, is another good option for your patients. So we have to wait a little bit longer. But if it takes a little bit longer, that's a good thing, because that means, in that sense, that means that patients are doing well, and we have to wait a little bit longer because they're doing so well. So I don't take it as a negative if we are waiting for the results. So now let's talk about PRRT, and then I'm going to share with you some results of recent studies that have been completed in the first line, the first round of PRRT, and then we can talk about some of the preliminary results that we have when patients are being retreated with PRRT. So I think you might have heard about the results of the NETTER-2 study, and if you haven't, I'm giving you a little flavor here. So the NETTER-2 study was a study that looked into the use of PRRT for patients that have a newly diagnosed, well-differentiated neuroendocrine tumor, but it had to be grade 2 or 3 with a Ki-67 of 10% or more and less than 55%. So these are tumors that are a little bit more aggressive, at least under the microscope, and the patients could be enrolled in this study if they have been diagnosed in the last 6 months before entering the study. The results were recently presented at GI International Oncology meeting called ASCO GI in January of 2024. And in these studies, we were able to see that lutetium-177 dotatate shows significant improvement into the primary progression-free survival endpoint. Progression-free survival means how long it took for the tumors either to increase in size substantially or for new lesions to be seen on the scans, and or if there is a significant event such as death of the patient. But in terms it takes for how long for the tumors to grow or for someone to have clinical progression or pass away from the disease. And then these studies, we can see that the progression-free survival of patients that receive lutetium-177 dotatate was 22.8 months. And then the patients that receive a high dose of octreotide intramuscular, the median progression-free survival was 8.5 months. And that's a huge, you can see in the graph here, that's a huge difference. Another thing that was very interesting, and we're still trying to understand why and need more details, is that when we look at the response rates of these tumors, meaning do the tumor shrinking size, the patients that receive lutetium-177, 43% of these patients had a substantial shrinkage of the tumors with therapy. And in the patients that had received the hormonal shot or the octreotide, the shrinkage of the tumors were seen only 9% of the patients. That's a big difference. We need to understand why. This is a study that enrolled patients with mid-gut tumors, but as well as pancreatic neuroendocrine tumors. It's unclear if that play a role, because typically we believe, yet needs to be proven, but we believe that pancreatic neuroendocrine tumors might have a little bit more sensitivity to response with PRRT. So we'll see as the data mature and the study team works in writing the manuscript and presenting the data a little bit more, we might be able to have some answers in regards to that. In terms of side effects, the most common side effects with this treatment were nausea, diarrhea, and abdominal pain, and the more severe side effects were related to decrease in the lymphocyte count, which is something that we might not feel it, but we'll see when we do some blood work. In terms of ongoing trials for the first round of PRRT, with the team of trying to develop a PRRT strategies to treat more aggressive disease, we have currently the COMPOSE study that is a phase 3 study that's looking to lutetium 177, but combined with erythritide, versus the best standard of care for patients with more aggressive disease, grade 2 and 3, and a Ki-67 of 15% or more and less than 55%. And then in this strategy, the comparator arm has a little bit more of, is believed to be responsive treatment, and they compare with chemotherapy with capecitabine, temozolomide, or FOLFOX, which is 5-FU and oxaliplatin, or everolimus. And then you and the physician decided what's the best comparator arm if on the study the patient gets enrolled, and then again is the random chance, right, is the computer randomization process that decides if you get the PRRT with the lutetium here versus the standard of care. And another thing that's interesting on this study, because they feel the thought process is that given that this is a more aggressive disease, there's a thought process that if we treat more intensively, we will do better. So in this study, patients can receive up to 6 cycles of PRRT, and the interval between cycle 1 to cycle 2 is actually shortened, is instead of the traditional 8 weeks that we use, is 6 weeks. This study is still enrolling, is in good process. The US is contributing heavily for patients in this study. So I think probably by the end of the year or early next year, we may have completion of the patients that needed to be enrolled in the study. And then will be a question of waiting for the results to mature to see the results. Another study that we have that I mentioned before, and that's an important study, is to try to answer the question if someone has a pancreatic well-differentiated neuroendocrine tumor that is either locally advanced or metastatic, what is after someone progresses on somatostatin alone, or if they have a lot of disease at the time of diagnosis, what is better? Is it better to do PRRT, or is it better to do chemotherapy with capecitabine and temozolomide? Because we know the capecitabine and temozolomide can be very effective on this population, as well as we believe that PRRT can be very effective in the pancreatic population. So when we have a patient with pancreatic well-differentiated neuroendocrine tumor that hasn't received either of those strategies, we pause and say, which one should we choose? And right now is a conversation and a balance with side effects, logistics of the treatment, and really the priorities of the patient and the physician should decide it. But we have a trial that hopefully will answer the question, and it's very important to consider this trial if this trial is offered to you at the place that you're getting treated for, because it really will help us to figure out, should we do one treatment before the other, and so forth. Another one that's important is about the use of PRRT for lung neuroendocrine tumors. We try to use it, but it's not a FDA-approved indication, so there are cases that we cannot get it for our patients. We do think possibly a good strategy, but we don't know, is that a better strategy than everolimus, for example? So doing this study, we're going to be able to answer if PRRT is a good strategy for neuroendocrine tumors that started in the bronchial area, and how it compares with everolimus, which is commercially known as Afinitor. And Dr. Suki Pada and Dr. Tom Hope are leading the study for Alliance, which is one of our national cooperative group trials that is sponsored by the National Cancer Institute. So let's talk about retreatment now. with PRRT. So the first study that we have is the NET Retreat, which is a phase 2 randomized trial to look into lutetium-177 retreatment versus everolimus in patients that have mid-gut neuroendocrine tumors, small bowel. So patients that are already treated with PRRT, if they progress, and it took more than 12 months for them to progress on treatment, there is the opportunity to consider this trial in which they then can be, the computer, again, randomization will choose between repeating lutetium for 2 cycles instead of 4 versus everolimus. But one thing that is reassuring, because we like to be given the opportunity of reconsidering PRRT until data shows that's not a good idea, is that patients that were in the everolimus cohort, they are able to, at the time of progression, switch and then at that point receive the lutetium. So even if a patient in the beginning gets randomized to the pill, if things continue to do well for the patient, there is always the chance that they can then, at the time of progression, receive the lutetium. So exciting trial. If, it's always a conversation with your healthcare team. If you have progression after receiving lutetium, would you be a good candidate for this trial? And then another trial that is ongoing, that I know that many in the community are looking forward to see results because of the radioisotope that is chosen, is the ACTION-1, which is a phase 1/3 global trial looking to retreatment of well-differentiated LACNETS that progress after receiving lutetium-177 in the past. And this is compared to some investigator's choice for standard of care. So the phase 1, which was looking to the safety, was completed, and I'm very excited to show the results of that in a minute. But right now, what is the option that is in sights is the opportunity to be enrolled and randomized to either receive the PRRT with the alpha emitter actinium-225 versus standard of care. Another important point to highlight is that patients that were receiving standard of care, which could be everolimus, sunitinib, or high doses of octreotide LAI or higher frequency of lanreotide, at the time of progression, if they continue to be well and fit all the eligibility criteria that the checklist on the trials, then they can be given and often the opportunity to, at the point, receive the alpha emitter. So these are the design for the part 1 of the trial that's looking to the safety. In this part, all the patients received the actinium-225. And here's the characteristics of the patients. The average age was 63 years old. Most of the patients were white in terms of the race, and about 11.8% of the patients were of Latino or Hispanic origin, and most of the patients were fit. In terms of characteristics of the studies, the patients on the study, so the median duration of the disease was about 5 years. More than half of the patients, the tumor started in the small bowel. Most of the patients had functional tumors. It was fairly well distributed in terms of the grade. And then all the patients received with lutetium-177 prior to being allowed in exposure in this trial. In terms of safety, all the patients had some sort of side effects that I will discuss it. More severe side effects were seen in 6 patients, but none of the side effects considered to be related to the study drug. There is no side effects that led for actinium-225 to be stopped. And I'm going to show you a little bit more here. The most common severe side effects were related to blood work. So we saw issues with anemia, with lower hemoglobin, issues with the lymphocytes. Some patients experienced some issues with changing the kidney function. And there were patients that passed away on the study, but they were not glad to feel that they were related to the study drug. So there was no documented fatal events, thankfully, on this study. Here are, again, the most frequent side effects, and I think it's a common theme of nausea, fatigue. Some patients had issues with high blood sugars, but issues with blood work, kidney function, and so forth. In terms of efficacy, 29.4% of patients experience a substantial shrinkage of the tumors, which are a total of 5 patients. There's one more that had one shrinkage that has to be confirmed. And 47% of the patients had stable disease, and 3 patients, or 17.6% of the patients, had disease progression during the study, meaning that unfortunately the tumors grow despite being on the new treatment. So the conclusion was that most common side effects were nausea, fatigue, and issues with high blood sugar, some decreasing the weight, and blood counts related to the CBC. But it was felt to be very safe. There were no concerns with toxicities that would mean that we had to reduce the dose of the radioisotope received, which is great. Essentially 30% response rates were seen, so 30% of the patients had a substantial shrinkage of the tumors. And now there is a continuation of that, which is the larger portion of the study, where patients are randomized to either receive the standard of care versus the actinium 225 PRT. And if they receive standard of care at the time of progression, if they fit the eligibility criteria or the checklist, then they can at the point receive the actinium 225. Right at the second, enrollment for the study is on hold due to radioisotope supply issues, but the company that is developing this study is actively trying to solve that supply chain issue. So we're all hopeful that this study is going to be active for enroll new patients in the very near future. Other recent studies that have been completed, I think you guys already heard from the CABINET study and Dr. Chen here at LACNETS, but I just want to mention because last year we showed this study, but we didn't have results, and now we have results. And essentially, the CABINET study look into the role of Cabozantinib for the treatment of well-differentiated neuroendocrine tumors. And they broke down the cohorts in pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors. And the patients were receiving either the Cabozantinib or a placebo pill. But at the time of progression, the patients were informed what they were receiving, and if they fit still the criteria, they could then at that point receive the Cabozantinib if they haven't done it so far. And then at the time was a 2-to-1 randomization, meaning there was a 2-to-1 chance that we will start with the Cabozantinib. This is the design. And here we can see the results in terms of progression-free survival. In the extra pancreatic neuroendocrine tumor cohort, the median progression-free survival was 8.3 months. And then in the placebo arm was 3.2 months. Here is the response rates on the study comparing Cabozantinib versus placebo. When we look at the pancreatic neuroendocrine tumor cohort, the progression-free survival with Cabo was 11.4 months versus 3 months with placebo. And the response rates are listed here. And you can see that with Cabozantinib, there was an objective response rate of 18%, meaning that 18% of the patients had shrinkage of more than 30% of their lesions, which is good for a TKI. So the study team concluded that Cabozantinib significantly improved progression-free survival of patients that have been previously treated, both in the pancreatic cohort and the extrapancreatic cohort. And the side effects or adverse events were very consistent with what we see in general with Cabozantinib. Cabozantinib is a drug that has been used in other cancers, such as renal cancer, liver cancer, and so forth. And Cabozantinib may be a new treatment options for patients that were previously treated and the tumors are growing. So that's very exciting that hopefully we will have a new option, and I'm sure it's going to be submitted for FDA approval, and then we will see. So stay tuned. Other ongoing trials that I just want to quick mention is one of the trials that I'm very passionate about and I'm blessed to help to lead, is to look into the role of chemotherapy after the resection of a pancreatic neuroendocrine tumor to decrease the chances of the tumor to come back in 3 years. This is a study where patients after their surgery, they can be randomized in a 2-to-1 fashion of receiving 4 months of the chemotherapy pills versus observations. And this is for patients that had resection of the primary neuroendocrine tumor, and at the time of resection also had potentially resection of up to 5 liver mets, and the patient and the surgeon feel that all the disease has been fully resected at the time of surgery. And then that's the opportunity to participate in this study. This study is only for pancreatic neuroendocrine tumors. It doesn't apply to other sites of disease. I also want to give a shout out to Dr. Perez and Dr. Del Rivero with their paraganglioma and pheochromocytoma study. It's a very orphan disease that we need all the help to develop new strategies. And this study is looking to the role of temozolomide plus or minus a PARP inhibitor to see if combining the oral chemotherapy with a second medication will help to improve the progression-free survival of these patients. This trial is open in few sites. I do have it at University of Utah, but this trial is open in the NCI, NIH. So if you are a patient and feels that you could potentially qualify, please discuss with your physician and ask your physician or healthcare team to either contact Dr. Del Rivero, or you can contact the NCI website for research, and then you can be considered for this trial. And if you are considered for the trial in the NCI, Dr. Del Rivero will help you to navigate, but your visits there will be covered by the study. So I think the take-home messaging continues to be what I think I mentioned a year ago, is exciting progress in the neuroendocrine cancer field. There are several ongoing clinical trials that might be a good fit for you. Just discuss with your healthcare team if there is an opportunity to be considered for a trial, and sometimes there are more than one opportunities there are few trials that could fit you. We discuss with your healthcare team and your physician what's the trial that makes most sense for you. And if we want to advance the field, and if we want to hopefully one day cure this disease, the only way to do that is with research. So from the bottom of my heart, please, if you're fit and there is opportunity for a clinical trial, consider that, because you can be part of the legacy that can hopefully change your life, but also change the life of many other patients that are living with this disease. That's what I have for you. I'll be looking forward for the Q&A session, and thank you so much for listening.
Thank you, Dr. Soares, for your very informative and inspiring presentation. I really appreciate your last words about how we can be part of the legacy, for ourselves, for other people, and that together we can advance the field forward. So we are really grateful to have you now answer questions from the audience. And I just want to remind the audience that this question and answer session is for educational purposes only. It does not substitute for medical advice. Please talk to your medical team with questions and concerns about your individual care or treatment. And as always, we get dozens, over 35 questions. We'll try to get to as many general questions only, and Dr. Soares will answer the questions generally. She cannot provide specific feedback on your specific situation. So Dr. Soares, again, thank you for joining us. And I will start with this general question. There's a lot of trials you covered today, and many of them sound so exciting. How do you as a clinician counsel your patient about clinical trials and how to consider them, and the specific considerations like the phase and the control arm, like you mentioned, placebos, or the medication if it's a new drug or an approved drug?
Yeah, thanks so much, Lisa, for number one, having me, and LACNETS for having me. You know me well, you know how excited I am to talk about research and clinical studies. So clinical trials can be considering any part of the journey, right? From prevention, if there are trials on prevention, to treatment when the disease had spread, or even when the disease has been resected. And we know that there is a chance of coming back. So are there any strategies that we can use to decrease the odds or the chances that the disease coming back? So it's really important to understand where a patient is in the journey to see which trial makes sense, and also see which trials a physician or a healthcare team might have in the organization. It's also important to see if the eligibility criteria of the trial matches the patient, or if the patient matches the eligibility criteria of the trial. For instance, a trial is looking at CAR T cell therapies, but when you look at the eligibility criteria, patients have to have melanoma or breast cancer, and they do not allow for a patient with neuroendocrine tumor to be part. So that's not a trial, even though it's exciting. Everybody wants to think about T cells for neuroendocrine tumors. A particular trial for that does not allow patients with neuroendocrine tumors to participate. So when I have a patient in front of me, I think, okay, what is the diagnosis? Do I have a trial that allows for patients with well-differentiated neuroendocrine tumor? Is there a limit on the cutoff of the Ki-67? For example, patients, the trial says that the Ki-67 has to be less than 30%. I'm making this up. Are the labs of the patient within acceptable range that we don't think the treatments could be too toxic for the patient, right? Typically, for most of the clinical trials, you have to have a kidney function, a liver function, and your bone marrow function to be within some acceptable levels of normality. They don't have to be perfect, but it cannot be a way off. And then you can be considered also the energy and the overall health of the patient. If the patient has a lot of clinical comorbidities or other medical problems, perhaps a trial might not be the best fit. Or if the patient is too weak and spend most of the day in bed, and it's even hard to come to the doctor's appointments, it's probably is not in the best of interest of the patient to be on the trial. And then I discuss all these things. And then I also, in my head, think, are the options that I have make sense for my patient, looking at the overall picture. And then I give my patients the advice. Sometimes I say, I do have this trial. I personally do not think that this particular trial is the best fit for you because where you are on your journey. In my rule of thumb, I always say this to the patients: I would not offer you a clinical trial that I wouldn't put my own family member. And that's something that I live by. Because if I pause and said, if my dad, who is living with a chronic cancer, or my brother were in this position, would I put my family on this trial? I don't, I inform that to the patients. I don't make the decision for the patients. I just share my opinion. And it's really a discussion. Sometimes we come back and say, okay, this is what I have. Why don't you think about it? I don't want to push you one way or the other. I don't want you to feel like you have to make a rush decision. We can have another virtual visit in a week or so to discuss. I know it was a long answer, but it's important for patients to understand that we have the best interest in heart for them.
Thank you so much. And it gives us insight on how that discussion goes. There's another related question from the patient standpoint. How do I consider clinical trials in my treatment journey? Specifically, how do I make the treatment decisions now that will not make me ineligible for future clinical trials?
Yeah, that's a tricky question because it really depends on the trials that you have in front of you, and try to anticipate maybe trials that will be in the future. For example, before PRRT was used a lot, we were doing a lot of radioembolizations for liver disease, right? And then some of the alpha emitter PRRT trials that we have, they exclude patients that receive radioembolization. But we didn't know 10 years ago that this was going to be an issue. So some of this is out of our control. And if you're thinking about the trials that you have right now, you can see, okay, these are the trials that I have. These are the standard of care options that trial A looks into, and these are standard of care options that trial B. So if the trial A, we choose different standard of care option, if you were to be randomized to the standard of care, perhaps if you choose a different one, that's not going to affect your capacity to go in another trial. Again, this is a conversation with the patients where you say this is currently the landscape, making this decision or that one might affect the possibility of this future trial, but we don't know how long it's going to take for you to need a new treatment strategy. So it's a little bit of the comfort. And honestly, in the end, thinking that you are doing the best decision with the counseling of your physician. But yeah, it's all great questions, and some of those are in your control, some of them are not.
Yeah, it's always a moving field, and you make the best
Mm-hmm.
decision at the time. Yeah.
Yeah.
Actually, I wanted to ask a follow-up question because you were talking about some of the ineligibility, like radioembolization or something like that. Do those criteria ever change during the trial or with the different phases?
Yeah, sometimes it does. For example, there is an alpha PRT trial that for the phase one will not allow prior chemotherapy with temozolomide, and then for the phase three, it did allow, but it didn't change for the radioembolization. Yes, sometimes based on feedback of given in the field or for the trial, things can evolve to be more flexible, or sometimes if toxicity could be associated with a particular eligibility criteria, it can be a little bit harder on that side. Let's say if we do a clinical trial that we see a lot of liver toxicity, perhaps the trial will be revised to make the liver function or the possibility of someone having cirrhosis to be included in the trial a little bit harder, not because we want it to be difficult and not provide the care that we need for the patients, but just to make sure that it's safe. Because the first rule that we live by is do no harm. And right, so we need to make sure that we are doing something that we do not anticipate that's going to cause harm.
Okay. Thanks for clarifying. So there's a lot of excitement about alpha, and you were mentioning it. So we'll transition to some questions about the alpha trials. So there's a question about the crossover. So the alpha, the Actinium-225 clinical trials allows patient from the standard of care arm crossover to the PRT arm. In general, how long does the crossover take when the progression is confirmed?
So for the crossover, if the patient is stopping the standard of care because of the tumors are growing, then there needs to be analyzed by the sponsor of the trial in the case of the Actinium-225. So that might take a few weeks because the imaging gets sent to the sponsor of the drug, and then that has been revised. And then the patients needs to come back for another eligibility checklist, get fresh set of labs, a new physical exam, double check the medications, and then there's a submission for the drug. So I would say they might take several weeks, certainly probably more than 4 weeks for the patient who was on standard of care to receive the Actinium-225. It can take longer than that. I don't want to mislead. There's a process to make sure that that's the right move for the patient.
Okay, thanks for explaining the process. And what, platelet counts are a concern for people who've had PRT in the past. What are the lowest values of a patient's platelet value, which disqualifies the patient from getting alpha PRT?
Yeah, each trial has different thresholds for platelet counts. Most of the times, trials tend to have a threshold of 75 to 80,000 for platelets, sometimes 100,000 for platelets. Many trials start with 100,000, and as you do the treatment, the threshold might change a little bit because decrease in the platelet count is expected to be seen in many patients, but there is a safety zone, right? If your platelet count came down from 100 to 76,000, you can still receive the treatment with no delays and no those adjustments. But if at the same time, if your platelet count came down to 50, that's a much impactful change, and therefore your platelet count needs to recover until 75. And then in the case of alpha PRT, that can mean that the next dose of your PRT will be reducing. But all this is actually very well delimited and explained on the clinical trial. We as clinicians, we just don't make up stuff as we go, right? We follow specific sets of guidelines that are explained in a given particular clinical trial.
Okay, thank you for that. So you mentioned the lead trial as well. Does the lead PRT lead to lead poisoning?
No, it's very different. They don't go along. There is no concerns to the traditional lead poison. And the phase 1 study that was done in neuroendocrine tumors with PRT using lead is very promising with good safety data and initial safety efficacy results with responses. So the phase 2 trial is ongoing. I believe they're very close to complete accrual. And we will see what the results will come from there. It's very exciting.
Yeah. Well, along those lines, this is the hottest question. Curious minds want to know how long will it be until N-alpha PRT trial is completed and submitted to the FDA for approval?
Yeah. So in terms of completion, when you look at the nciclinicaltrials.gov, the companies that are conducting these studies, they're supposed to put when they expect the trials to be completed. And the expectation is that these companies will have completed by 2026. Assuming that the results are positive, then there's the time process of submission for the FDA. And I don't think we will have any direction on that, probably at least until 2027. I might be wrong. As an evolving field, things might get, patients might complete the trial sooner or later, than we initially expected, and this is dynamic. But in general, if you look what the companies put in the websites, I don't think we'll have any clear direction if it's a go, no go until at least 2027.
Thank you. So we will eagerly await more information. Okay. Along the lines of other PRT questions, if the density of somatostatin receptors is less than ideal, do PRT and somatostatin analog treatments take longer but work as well?
Yes. So if your amount of receptors is not the greatest, it might not be an ideal option for you. When we look at the NERA-1 study and a few other studies, we know that the higher the somatostatin analog expression on the tumors, the higher the chances that the treatment will work well. And it's also there's a minimal cutoff that your expression of somatostatin analog that's acceptable for a patient should be considered for a clinical trial. Typically has to be above the liver background. So if you look at the uptake in the liver in general, the yellow in the liver, I tell my patients, and you look at your tumors needs to be more yellow than at least the background of the liver. If your tumors are not, then PRT and most likely somatostatin analogs are not a good option for you. There are several discussions and preclinical studies trying to see if we can develop a strategy to make the receptors be more present, and then if they're not there in the tumors, can you make them show up? Can you make them sterilize? So then, if they come out of the tumors, then we can use the somatostatin analogs or PRT. There's a lot of studies on that, but nothing ready for prime time yet.
Yeah, nothing ready for prime time. And there was a question about one of the study. Could you speak about the synergism with PRT and CAPTEM? And this person put in a specific journal article.
Yeah. So there's a lot of studies and trials going on about combining PRT with different agents to see if PRT can work better. And especially in this study was a study that looked into PRT with CAP10. CAP10 is capecitabine and temozolomide, these two oral chemotherapies. And they look into PRT with CAP10 or PRT by itself. They numerically show that the response rates with CAP10 PRT were higher, but there was not a clear statistical difference. I think there was a signal that needs to be explored more if that's the direction that the investigator wants to go. It's also there was a little bit more toxicity, particularly with bone marrow toxicity, because both treatments can cause issues with blood counts. we're also becoming more acutely aware of the chances of the use of PRT and CAP10 not together, even in separate. That will increase the risk of someone developing leukemia or MDS, and that's another consideration. If there is a different strategy that doesn't increase the risk of MDS and acute leukemia, perhaps there might be something to look over PRT with CAP10, but there are studies that have looked into that.
Okay, thank
I
you.
don't use together. And I mean, exactly at the same time. I use a lot of CAP10, I use a lot of PRT, but I don't use them combined.
Definitely something that is not ready for prime time. So this question reminds me to take a step backwards. Some people are on PRT, I'm assuming Lutathera, and just wanting to know more about the efficacy in small bowel NETs and long-term side effects. And I know we're talking already about alpha and such, but if we could just kind of take a moment to recap.
Yeah, so the NETTER-1 study actually was that was the study that led to the approval of lutetium-177 in the U.S. Was actually done only in midgut tumors or small bowel tumors, and in that, in terms of response rates or tumor shrinkage, that was seen in 18% of the cases of the patients that had received lutetium. The progression-free survival was also very high. It was more than 28 months, and the survival even higher. So we know that it's extremely effective in well-differentiated neuroendocrine tumors. We know that the NETTER-2 study, they looked into patients that had GI LACNETS and had a Ki-67 that was 10% or more and less than 55%, the response rates in the tumor were even higher. What we don't know if the group that had this highest response rates is the group with small bowel versus perhaps the group for pancreas. The data was shown in our overall pool of patients, and I think once the publication comes out, we probably will have the breakdown to see if the higher response rates were because of tumors in the pancreas, because we do believe that maybe pancreas neuroendocrine tumors respond a little bit more in terms of tumor shrinkage compared to small bowel. Remains to be seen, so we're waiting for the publication. In terms of efficacy of progression-free survival, when they broke down and showed the subgroups of pancreas versus no pancreas, the benefit was very similar in both. In this group of patients that have a little bit more aggressive neuroendocrine tumors with G2 and G3 related to the NETTER-2 study.
Thank you. And I know we have many resources, videos, and podcasts for more information on PRT for this person or others. So this is a good question. You talked about the AlphaMedix led to 12 trial. Will there be a phase 3 trial for the AlphaMedix treatment soon?
Great question that I'm no position to answer. You probably have to contact Dr. Dopasens and AlphaMedix team and ask them.
Thank you. So moving to immunotherapy, this is another hot topic, as you're aware. What updates do you have on CAR T or immunotherapy? And what are your thoughts about the CAR T clinical trial?
Yeah, so even any strategy that would increase the activate the immune system to fight neuroendocrine tumors. Traditionally, the IV immunotherapies that we use, all the studies that are looking into that for the well-differentiated, low-grade, intermediate-grade neuroendocrine tumors has not been that successful. We use sometimes, particularly in patients that have a higher grade of Ki-67. But now there have been a lot of advances in CAR T, including for neuroendocrine tumors in the sense of preclinical studies. There are several investigators that are looking into that. Dr. Mauro Sives in Bari, Italy is one of them. The group on UPenn has also done a lot of work on that. They have been funded by the NetRF group, the Net Research Foundation, and from many years, and that is nice to see that the funding led to really more concrete solutions. To the best of my knowledge, there is a CAR T cell study that is going to be open, and I think it's going to start with the University of Pennsylvania. When you look at the official information, it's projected to be active, I believe, in June of 2024. I don't have any more information. The trial is not active yet, but that is one trial that is going to be targeting and accepting patients with neuroendocrine tumors. They also are going to include patients with esophageal cancer and I believe colon cancer, but it will allow for neuroendocrine tumors. Also, I mentioned Dr. Mauro Civis. He has done extensive research in the field. I think all his preclinical studies look very promising, and my understanding is that if funding becomes available, he and the group from Moffitt with Dr. Strasberg could potentially conduct the initial phase 1 trial to look into the toxicity. So we need funding, we need financial support for our also investigators to continue to bring therapies to neuroendocrine cancer. There's other therapies too. There is BITE therapy. There is one that I'm sure it will be talked next month when Dr. Shaman does his presentation that is expected to be approved in June for small cell lung cancer. They're testing in non-small cell neuroendocrine carcinomas as well. So lots of excitement in the field.
Yeah. So for the CAR T, the Penn study, and then the one out of Moffitt with Mauro Civis are ones.
Moffitt, I think they are looking for funding. And then the one from university that I mentioned that I think will be conducted under the guidance of Dr. Eads, I believe is a pharma-sponsored trial with an Australian company. And Dr. Eads, I think, is the principal investigator and listed in the website, but it's not enrolling yet. So please don't bombard Dr. Eads yet with emails because I don't think it's active yet. She wouldn't be able to bring patients for the study right at this second.
Stay tuned. We will keep watching.
I'm sure you probably will bring her to talk about it.
Yes, we are working on that once it opens for enrollment. Yes.
Yeah.
What about, this is another excellent question. What about immunotherapy with chemotherapy?
Yeah, we actually, the NCI sponsors a trial looking into chemotherapy with immunotherapy for patients that have high-grade neuroendocrine carcinomas. All the studies that have been done in the well-differentiated neuroendocrine tumors have not been promising, both with chemotherapy or even in associating immunotherapy with a TKI or FAPU, right? Moffitt has done Tamia Aldobat has presented even NNETs and ENETs, the combination of some TKIs with immunotherapy, and it was not something that felt that was promise enough to move the next step. So it's still not something that we are using in well-differentiated neuroendocrine tumors. I know that we use a lot in other diseases in the GI tract or in the from the lung, but not ready for well-differentiated NETs yet.
Okay, thank you. Are there any trials coming in the future for those with NETs whose tumors do not have somatostatin receptors? And I know you've been talking about some of them.
Yeah, so these are trials that probably will not include PRRT. So if there is any new pill TKI, that will be a trial that will be doesn't require patients to have a positive somatostatin receptors in the tumors. The Cabozantinib trial didn't require that, the cabinet trial, so this was a good option for patients that didn't have that. The capecitabine temozolomide trial for pancreatic neuroendocrine tumors that was conducted and completed a few years ago didn't necessarily require that. Our adjuvant trial, SWOG 2104, for patients that had the tumor resected, and then we think that there's no more tumors that we want to decrease the chances of the tumors to come back, do not require patients to have positive somatostatin analog. Typically, there will be trials for patients that do not qualify for PRRT, unless it's one of the trials with PRRT that is giving a drug for a patient to see if that can make the expression of the tumors, receptors in the tumors to increase, and then to use PRRT. But it will be the minority of them.
Okay, thank you. Are there any trials for detecting and treating chemo-resistant cells?
Not directly phrase like that. We don't, to the best of my knowledge, and please, if someone is aware and I'm just not fully educated on that, I'm sure they can let you know and you can disseminate that. But I'm not aware of any trials on that sense.
Okay, thank you. So NET patients often post about their metastatic NETs returning months after they were surgically removed. How often do metastatic NETs return after surgery?
Yeah, that's a complicated question in the sense that really needs to take into account where the tumor started and how aggressive is the tumor. So if we think about pancreatic neuroendocrine tumors that are well differentiated, and if they have a lot of positive lymph nodes, there's a chance that in a period of 10 years or more, then these tumors will come back 40 or 50%. If this is a small bowel tumor that there was no lymph nodes that were involved, then the chances of the tumor coming back are much less. If there are positive lymph nodes involved, then your lifetime chance of this coming back, if there was a lot of positive lymph nodes involved when you resect it, that could be as high as 40 to 50%. And again, we don't use the traditional 5 years. Oh, if a tumor doesn't come back in 5 years, you are cured, because this is thankfully, is a very slow growing disease that it might take more than 10 years for us to see a tumor coming back. So it really depends on the location and how aggressive the tumors were to begin with, like the Ki-67 and how many lymph nodes are involved. If someone had metastatic neuroendocrine tumor, the GI picking up on the GI tract that was resected, including the liver mets, the chances of coming back are much higher. And then we can look in the 96% of the time tends to come back in the first 5 years, and the median average, when you look at some of the retrospective data that is around, can be between 1.5 to 2 years. And I'm doing a very rough estimation, putting a bunch of different publications together. So when I discuss resection of liver mets with patients, I try to explain that we shouldn't necessarily think that the tumors will be cured, but it certainly resets the clock. And by time without having disease that you need to intervene. But it's hard to think if tumors had already spread to the liver that we can 100% guarantee that with the resections, they will be cured.
Thank you. What about serotonin? Are there any upcoming trials aimed at reducing serotonin?
Well, we discussed the completion of one of the studies with the oral somatostatin analogs that also decreases the 5-HIA levels, by default, the serotonin levels, PRRT, and reduces. If you want to think about just the hormone per se, no, but we have plenty of studies either for tumor control or for symptom control that will decrease the levels of serotonin or 5-HIA.
Thank you. Are there any trials for low burden of grade 3 liver NETs, and also trials or studies around TP53 mutations?
Yeah, I'm trying to see how I can digest the initial question about low burden of disease on grade 3, right? Because, for example, the pancreatic neuroendocrine tumor allows for resection of the liver lesions if they're up to 5, and then you can do the chemotherapy later. So I don't think none of the trials specified the number of lesions in the liver that to decide, most of them, if a patient is eligible for the study. Any trial that looks into metastatic, well-differentiated grade 3 should take into account that, and shouldn't be exclusion, because we know that liver mets are seeing most of the patients. And in terms of trials for P53 mutation, none of the studies that I can think of are specifically for neuroendocrine tumors. These tends to be trials, many are phase 1s and phase 2s. They're looking to the efficacy and safety of drugs for P53 mutations in different tumors. And if a patient has a neuroendocrine tumor, there's a good chance that the patient could be allowed, especially if the trial is tumor agonistic, meaning doesn't matter where the tumor is coming from, as long as there's the mutation, you could be eligible for the study. But I cannot think about anything in the NET field that is specific for that.
Okay. How about ATM genetic variant patients? It seems immunotherapy is becoming more prevalent.
Yeah, same. I cannot think about a trial that dedicates only for neuroendocrine tumors with ATM mutations, but there's a lot of phase 1, phase 2 trials that allow for different tumor types to be included, and then neuroendocrine tumors can certainly be one, and there are trials combining with immunotherapy or trying to assess if the response to immunotherapy is better with if a patient has ATM mutation or not.
Belzutifan. Is belzutifan applicable to patients who have somatic VHL mutations? And then what about high-grade PNET patients who have somatic VHL mutations? And if you could briefly explain what belzutifan is as well.
Yeah, it's a drug that has been approved as a HIF alpha inhibitor that is oral medication that has been approved for patients that have tumors associated with the VHL mutations. And when the initial study was completed in kidney cancer, the investigators saw that the patients that had kidney cancer and also have pancreatic neuroendocrine tumors, because VHL mutations also predispose you to have pancreatic neuroendocrine tumors. These patients had a very good response on the pancreas tumor. So now there's an ongoing trial looking to VHL mutations, period, regardless of how they are, looking to patients with neuroendocrine tumors, paragangliomas, and I think, just if I'm not mistaken, I do not have the trial here at the Huntsman Cancer Institute, but to the best of my recollection, is allowing for these three groups of patients. And if one goes to the clinicaltrials.gov, they can see which sites the trial is available at.
Let's shift to non-pharmaceutical and the interventional radiology field. Are there any updates on interventional radiology trials pertaining to embolizations?
Yeah, the Dr. Suleiman's trial looking to chemoembolizations versus blend embolizations for metastasis from neuroendocrine tumors had completed accrual, meaning that he got all the patients that he needed to analyze, and now we're just waiting what's called for the data to mature, meaning we need some time to see what happened to the patients and the lesions, and then he'll be able to present his results. We're waiting on that. I was part of that study. We opened that study here with Dr. Sisman in collaboration with Dr. Solomo, and now we're following the patients and waiting. And once we see that there's a determined preset number of events that we feel that we're ready to report, then the publications on that will be coming out. So stay tuned. And I don't think there's any other larger trials on embolizations. I'm sure there might be different institutions with a particular focus and doing trials, but nothing on the national larger scale that I can think of.
Thank you. I know Dr. Michael Sulin will be, who you mentioned from Penn, will be speaking for our June conference as well. So we look forward to hearing more.
So he probably can share a little bit on the status of the trial.
I hope so. So what about microwave ablations for PNETs, I guess, in general for NETs? Are there any medical centers enrolling or reporting results regarding patient outcomes?
Yeah, and I don't know where there's a difference of the microwave, the sound ablation. So there's a lot of retrospective data and cases of institutions that have been done. We do ablations in many patients. Normally, we try to respect a maximum size of the lesions to be considered for that. Is certainly an option, and depending on the situation can be discussed with the patient, depending on the goals and how many lesions, to decide, okay, there's only one lesion, is that better than doing liver direct embolization or resection, and why? But then there's the sound wave type of ablations that I'm sure we'll be talking more soon. So I'll wait for that.
That's actually my next question. There are several questions on this. I put them together into one. Where is histotripsy being done? I know you didn't talk about it today. We have some past educational webinars and videos on this. Where is histotripsy being done, and can histotripsy be used for tumors greater than 5 centimeters yet?
Yeah, so thanks for the question, because patients ask all the time. And now we'll refer the patients to the awesome series of educational material that you have on your website. I hope you share later. So histotripsy is the application of this sound wave delivery of ablation energy for patients that have liver lesions is done by a specific machine that was just recently approved for the FDA for all tumor types in the liver. Including neuroendocrine tumors. There is not a specific trial that has been conducted and published specifically for neuroendocrine tumors. So I think whether it can be done in tumors larger than 5 centimeters is hard to say, because we haven't even looked into neuroendocrine tumors. In terms of where can be done, I think if you refer to the website of the machine, of the company. They list the sites that are doing, but I can think on the top of my head that obviously Denver with Dr. Eric Liu, University of Chicago, where a lot was being developed. I think Seattle and the Swedish center is doing. There are a few more centers that are doing. We're not doing that here at Huntsman Cancer Institute quite yet. I think we're just waiting a little bit to see how the data for neuroendocrine tumors is going to pan out. And also another thing that we are trying to learn is, like, should we do this earlier for patients that have low burden of disease, or should this be considered for someone that has a much higher burden of liver disease, right? I just had a little bit of this conversation with Dr. Liu this week when I was seeing a patient, and I call and I say, okay, this could be an option here. And then I wanted to pick on his brain, since I know that he's very excited to be offering that for patients. So stay tuned. I think as we are doing more, as a community, we're going to be learning more about where we should use it, and hopefully also the company is going to be sponsoring and supporting trials that are dedicated for neuroendocrine tumors, because again, what it works for one type of tumor might not work for another, right? Liver mets from different diseases can behave very differently.
Thank you for that very thorough answer. Going back to high grade, I know we didn't really cover this today. Are there trials for high grade or poorly differentiated neuroendocrine carcinoma planned?
Yes, there is few sponsored by companies, but there are some ongoing trials that will benefit from patients' consideration. So there is the trial that I mentioned in the earlier, looking to a first-line strategy, meaning the first treatment that you get for patients that have poorly differentiated neuroendocrine carcinomas, looking into chemotherapy itself, which is normally how we do it, versus chemotherapy plus immunotherapy. That's a SWOG trial, and is opening multiple sites. Is open for any extrapulmonary high-grade poorly differentiated neuroendocrine carcinoma, GI tract, gynecology, or prostate. They're all allowed, just to give examples. That's one trial. Then there are trials that are looking into using medications for patients that are refractory. Fox Chase is doing a trial with chemotherapy plus oral medication that hopefully will helping to the chemotherapy to work better, and to answer the question of resistancy. Now that I think differently, the pill that is given together will, or the medication that's given together, will hopefully overcome some of the chemo resistance. And so that's a trial in Fox Chase that we also actually have at Huntsman. And then there are several other mainly phase 1 studies that have a target that is potentially a receptor or target that's prominent in neuroendocrine tumors. So they allow for neuroendocrine tumor patients. We have few here at Huntsman, and some of them are national trials. It's just a question of discussing with your healthcare team and finding a trial that makes sense for you and put the referral there.
Thank you. And I know Dr. Manchohan will cover this in
Yes.
detail next month as well. So we look forward to more of that.
You should not
And
miss his talk because he's an awesome teacher and speaker, and he knows his stuff. So I'll be watching with you.
excellent. We look forward to that. So shifting to G3-NET, I know you talked about immunotherapy, but this question about comparing CAP10 versus FOLFOX as a first-line treatment for G3 pancreatic NETs or NETs in general, what do you think about that? Is there anything planned to compare those two?
Great question. We don't tend to use FOLFOX as the first line for pancreatic NETs in the US if they are well differentiated. If they're poorly differentiated, this is a different story. But I think the question is for first line. The FOLFOX can come a little bit with the peripheral neuropathy if you use for a long time. It's certainly something that's not wrong. It's just not how the way we do it. There is the Compose study that is looking into PRRT in a more intense way and compares against standard of care. And the standard of care can be CAP10, FOLFOX, or everolimus for patients, right? That's a great trial. And that is going to look into patients that really have a more aggressive, well-differentiated neuroendocrine tumor with a Ki-67 of 15% or more, up to 55%. So most of the bulk will actually be grade 3. It does allow for a little bit of the grade 2s that are a little bit in the higher Ki-67, and then patients are randomized to either PRRT, and the way that the PRRT is delivered is a little bit more intense. So they propose up to 6 treatments with PRRT, and between the first and the second treatment is only an interval, assuming the patients are okay and recover well from other toxicities, of 6 weeks instead of the traditional 8 weeks. And that is a great trial that will answer the question of, is a systemic treatment better, or PRRT in this more aggressive schedule better for patients that have a more aggressive disease? The NETTER-2 answers some of that, but the NETTER-2 study compared again a higher dose of somatostatin analog. So this is going to be another study that when comes out will be very important to guide this in how to do this. And the Compose study is not only for pancreas neuroendocrine tumors and get all GI tract neuroendocrine tumors. They have a higher Ki-67.
Thank you for highlighting these important trials. So we'll end with this last question. What advances in the neuroendocrine tumor field are you most excited about this year? And I would also add, a year from now, if you had a magic ball, where do you hope that you will be sharing, like in terms of updates and where we'll be next year?
Gosh, so much. I certainly hope, and I know that Dr. Shaman is going to talk, I certainly hope that we have more options that are approved by the FDA for poorly differentiated neuroendocrine carcinomas, because that's a very aggressive disease that we don't have a lot of advances in the field. I hope if I were to give this talk again next year, that I report back that all the accrual for the alpha studies are completed and we're just waiting on the results, and then alpha hopefully will be another option for patients. I hope that I will be coming back and saying that we have at least 2 or 3 trials looking into CAR T cell therapies for neuroendocrine tumors, and that our retreatment, right, that we know a little bit more about retreatment, both from the alpha study and also even from the lutetium study that is ongoing. So there's so many studies that once we have the results, and if the results are positive, will potentially impact substantially the life of our patients. I don't know that we'll have all these answers by next year, but hopefully there's more smart people that will come back with even new strategies. And hopefully we will also develop new strategies for when patients have their surgery and we know that there's a higher chance of the disease coming back, that there is other strategies to overcome that. Another thing that we didn't talk that much is with PRRT before surgery. There's a lot of discussion. Some studies have been done, but we don't have any large study on that. So hopefully, maybe someone will open a study looking to another larger study and look into the role of neoadjuvant PRRT to help us to see if that's a good place to put PRRT on as well. So much I can talk forever about this. So.
Well, we really love and appreciate your passion about this. It sounds like there's a lot of moving parts thanks to smart and dedicated people like you. And we really appreciate the opportunity to learn about the latest in clinical trials, including the results of recent trials, the trials to continue to watch. We really want to thank you for all your hard work and dedication, for all you do for the neuroendocrine cancer community. And we hope that together we can help move the field forward to find new treatments and stamp out disease. Thank you for giving us hope. Thank you for all you do. And I'm going to send it back to Heather in the studio to close this out.
Thank you again, Dr. Soares, for your informative presentation and for answering so many important questions on clinical trials from our audience. We appreciate our supporters, Ipsen, ITM Pharmaceuticals, Tercera, and Crinetics. Educational programs like today's are made possible by donors like you as well. Please consider making a donation today at lacnets.org/donate. And a special thank you to our technical director, Rich Tamayo from TVP Live for this high-quality broadcast production. Again, follow us on social media to stay up to date on our upcoming events. Our handle is @LACNETS. And now back over to Lisa.
Thank you, Heather. LACNETS is a community of support and resources. We recognize that you are more than your disease, and we aim to support you as a whole person. To this end, we offer many resources and programs. Find out more on our website, lacnets.org. LACNETS is a monthly podcast featuring experts who answer the top 10 questions in their field. Go to our LACNETS podcast page to check out the episode transcript, resources, and the top 10 questions we asked the expert. Thanks again for joining us today. We look forward to seeing you next month. Bye.